Welcome to The Explainer. I am so thrilled you're here. Today, we're exploring a foundational concept in healthcare that's going to completely shift how we approach our younger patients. The big overarching theme we are unpacking today is that pediatric patients are absolutely not just miniature adults. They have highly specific, uniquely developmental needs that require profound adaptations in our clinical care. And we're going to break down exactly what those adaptations look like on the floor.
Let's kick things off by challenging a really dangerous misconception. The whole idea of the mini adult. You know, if a child weighs half as much as an adult, why can't we just give them half the adult dose of a medication? Well, as we're about to see, the differences aren't just about size. They are fundamentally physiological. From how their stomachs absorb medications to how quickly they lose oxygen, a child's body operates in a completely different gear. Understanding these differences isn't just helpful, it's absolutely critical. High-yield knowledge that literally saves lives. Here is our roadmap for today. We'll be covering welcome to pediatric care, collecting baseline health data, calculating safe pediatric dosages, administering medications safely, and finally, specialized pediatric procedures.
Let's jump right into Section 1, Welcome to Pediatric Care. Safety begins before treatment. Now, these rules might seem super basic, but trust me, they are vital. Accidents are actually a major cause of death and injury among infants and children in hospitals. So basic environmental checks, totally non-negotiable. We've got to verify ID bracelets before any care. Remember, infants can't exactly tell you their name. Crib sides must be up and locked the second you step away. Weights must be documented strictly in kilograms to prevent massive dosing errors. And we always have to actively scan the room for things like sharp toys or meds left within a curious toddler's reach.
To adapt our physical safeguards, we use specialized tools. Take the hard plastic bubble top crib extender, for instance. It's absolutely essential to prevent a climbing toddler from taking a dangerous fall right out of their crib. And when it's time to administer care, the hug restraining position is a game changer. The caregiver safely pins the child's limbs while providing comfort. Kids have totally unpredictable, uncoordinated movements. Properly securing them protects them from accidental needle sticks or procedural errors without causing any unnecessary trauma.
Moving right along to Section 2, collecting baseline health data, age-specific assessments.
Okay, the crucial point here is the order of operations. Let's be real for a second. If you walk in and immediately slap a cold blood pressure cuff on a tiny infant, they are going to scream. And a crying baby, that gives you completely inaccurate respiratory and heart rates. That's exactly why we use the least to most invasive rule. Step 1, just look. Observe their color and count respirations while they're perfectly calm. Then, use minimal touch to listen to the heart and lungs. Save all the invasive things, like blood pressure and reflexes, for the very end. And finally, always swaddle and comfort them afterward. And speaking of blood pressure, we aren't just stuck using the upper arm. In pediatric care, using the popliteal artery right behind the knee or the posterior tibial artery near the ankle is incredibly common and super effective. But here's the golden rule. Making sure you have a correctly sized cuff. A cuff that's even a little too small or too large will give you a totally false reading, which can cascade into completely incorrect and potentially dangerous clinical decisions.
So getting a clean catch urine sample from someone who isn't potty trained? Yeah, that's a unique challenge. You have to clean and fully dry the skin, no powders or lotions at all, or that adhesive bag just won't stick. But here is a fascinating clinical trick. Once the bag is applied, placing a cold, damp washcloth directly on the infant's lower abdomen can stimulate their nerves and trigger them to void almost instantly. It's a massive time saver and really minimizes the child's discomfort. Next up, Section 3, calculating safe pediatric dosages, metabolism, and math. Remember our hook at the very beginning, why kids aren't mini adults? Well, this is exactly why. Think about the physiological contrast. An adult has mature, predictable stomach acid and transit times. An infant, on the other hand, lacks free hydrochloric acid, meaning medications that require an acidic environment won't be fully absorbed. On top of that, infants have a crazy rapid intestinal transit time. Medicines might literally pass right through them before doing their job. Add in those immature liver enzymes, and you realize drug metabolism in kids is just a whole different ballgame. Because of these wild metabolic variations, simply guessing based on age is a huge no-go. That's exactly why we use body surface area, or BSA. This is the primary gold standard for calculating safe pediatric dosages. By using a specialized chart called a nomogram, we map the exact intersection of a child's height and weight.
It gives us a precise surface area calculation that directly correlates to how their body will distribute and metabolize a drug. Doing the math empowers you to be the ultimate final line of defense for your patient. Just because a provider ordered a specific dose does not guarantee it's safe. It's your clinical responsibility to verify the milligrams per kilogram against safe ranges. High alert medications, like insulin and digoxin, absolutely mandate an independent double check by a second nurse. You are the advocate ensuring the 6 rights of medication administration are perfectly met every single time. All right, moving to Section 4, administering medications safely, precise sites and techniques. I want you to burn this number into your memory. 0.5 milliliters. This represents a critical, unbending safety limit. It's the absolute maximum volume for an intramuscular injection in an infant. Their tiny muscle fibers simply cannot absorb more fluid than this at one time. Pushing more than half an ml into an infant's muscle, that can cause severe, lasting tissue damage.
So where exactly does that injection go? For any kiddo under 3 years of age, the vastus lateralis muscle in the thigh is your mandated absolute go-to site. Why? Because the gluteal muscles, the buttocks, are dangerously undeveloped in infants and toddlers. Using the gluteus at this age poses a massive, unacceptable risk of hitting and permanently injuring the sciatic nerve. No way we want to risk that.
Even something as simple as eardrops requires a structural adaptation. Children's ear canals aren't shaped like ours. To deliver medication effectively, you've got to straighten the canal. For children under 3, you pull the pinna, the earlobe, down and back. But for older children and adults, you completely switch it up. You pull the upper auricle up and back. If you use the wrong technique, the medicine just pools on the outside and never actually reaches the eardrum. Finding an IV site is an entirely different adventure. Because infants lack peripheral perfusion, you won't always find those nice, robust arm veins we use in adults. Instead, we rely on highly specialized lifesavers, the superficial scalp veins and the dorsal veins right on the top of the foot. These are absolute game changers when traditional arm access just isn't happening. But getting the IV in, that's really only half the battle. Maintaining it is a psychological game that evolves as the child grows. Infants need arm boards and pacifiers for soothing. Toddlers, who, let's face it, are naturally chaotic and oppositional, require securely anchored IVs, constant supervision, and heavy distraction through play. By school age, they need fewer physical restraints, but far more cognitive support. Explaining the procedure and giving them a heads up really builds their trust and compliance. Finally, let's dive into Section 5, Specialized Pediatric Procedures, Airway and Nutrition. When an infant has severe anatomical anomalies, strictures, or a non-functioning upper GI tract, they physically cannot take food by mouth. A gastrostomy button solves this by bypassing the mouth and esophagus entirely. It provides a highly secure, surgically placed route directly through the abdominal wall and into the stomach, ensuring the child gets vital nutrition without the massive risk of choking or aspiration. When dealing with the pediatric airway, time is quite literally oxygen. If a child has a tracheostomy tube that needs clearing, you absolutely must limit your active suctioning to no more than 15 seconds flat. Kids have a much smaller functional residual capacity than adults. They deplete their oxygen reserves incredibly fast. Suctioning for too long can throw an infant into rapid, life-threatening hypoxia. And if an infant is choking, our physical maneuvers are completely different. Please do not do a standard abdominal Heimlich maneuver on a baby. You will rupture their internal organs. Instead, we sandwich the infant face down along our forearm and deliver 5 forceful back blows right between the shoulder blades, followed by 5 chest thrusts. And remember, never ever perform a blind finger sweep in a child's mouth. You'll likely just push the object deeper into their tiny throat. Wow, we've covered some incredible ground today, from alternative IV sites to the precise math of metabolism. So I want to leave you with this provocative question to reflect on. As a pediatric advocate, how will you take these high-yield textbook adaptations and translate them into compassionate, safe, and precise daily practice? Because remember, they aren't many adults. They are entirely unique patients relying completely on your specialized knowledge. Thanks for joining me on The Explainer, and keep learning.